Hello everyone, and I'd like to welcome you to this recording for FH Awareness Day 2024 on the topic of FH, obesity and diabetes and the links and consequences. I'd like to introduce our special guest to you, Dr. Amany Elshorbagy. She is a cardiovascular epidemiologist at Imperial College London, and she's also a Professor of Medical Physiology at the University of Alexandria in Egypt.
Very much for the introduction, Emma, and thanks a lot to FH Europe for inviting me to this webinar.
Absolute pleasure to have you, Amany. So with the subject of FH, obesity and diabetes, I think in the initial stage, it would be really helpful if you wouldn't mind explaining what FH is, what obesity is, and what diabetes is as well, please.
Sure, thanks, Emma. So basically, we all think of obesity as an increase in body weight, right? We think it's an unhealthy increase in body weight. And some people will be aware that this is how we actually assess obesity in most studies and how a person can assess whether they're normal weight or not. So it's often calculated as the weight in kilogram divided by the square of the height in meters, and that is called the body mass index. And people with a body mass index of less than 18.5 are considered underweight, whereas a healthy weight is somewhere between 18.5 and 25. A BMI of 25 to 30 is overweight, and more than 30 is obese. But then the Obesity Medicine Association, they have a kind of a long technical definition, which kind of helps us understand the links between obesity and diabetes, and also their links to cardiovascular disease. So it's diagnosed, it's actually defined as a disease because there's now treatments for it. It's a chronic, progressive, relapsing and treatable disease.
Good to hear it's treatable as well, Yep.
Wherein an increase in adiposity will promote adipose tissue dysfunction, resulting in adverse metabolic, biomechanical, and psychosocial health consequences. And this long definition takes us to the focus on the adipose tissue or the fat tissue, because we're all aware that if someone is doing bodybuilding and weighs 150 kilos, we're still not going to consider them obese because we're aware that actually this weight is largely muscle. So the unhealthy bit in the obesity is actually the accumulation of fat. And the problem with accumulation of fat in obesity is that it's not just these small innocent fat cells and then you sort of accumulate a lot of them in different places. The problem is that the fat cells themselves become sinister. So they become hypoxic, lacking in oxygen, and then they start sending unhealthy signals in the blood. They start to be infiltrated by fibrous tissue, and crucially, immune cells will start accumulating in the adipose tissue and will start releasing inflammatory cytokines. There's also going to be, in association with obesity, an increase in lipolytic activity and a release of fatty acids into the bloodstream. Now, what all of this does is that it starts to make all the peripheral tissues resistant to the action of insulin. Now, this is how obesity leads to insulin resistance. It's basically, so you know that insulin gets released after a meal because it's insulin. We need insulin in order for the glucose to enter inside the cells, inside the body cells. What happens in insulin resistance is that the cells become resistant to the action of insulin, as the name implies, and they need the pancreas to secrete excessive amounts of insulin to get the same effect of lowering the blood glucose. Now, the pancreas continues to do this, and you get a stage of insulin resistance where a person's glucose is actually normal. You wouldn't diagnose them as diabetic or anything, but their insulin is extremely high, and they're only able to achieve this normal blood glucose using excessive secretion of insulin. When this goes on for years, and also with the toxicity to the pancreas from the excess lipids in the bloodstream, the person will develop, some people will develop overt diabetes. Now, diabetes is characterized by a deficiency of insulin as well as insulin resistance. Now, both of these, both obesity and diabetes, result in something also quite serious called dyslipidemia. And dyslipidemia is an increase in the abnormal lipids in the bloodstream.
Okay, may I interrupt just for a second on a couple of points? So with the diabetes that's developed from obesity, is that specifically type 2 diabetes?
Thanks, Emma. That is type 2 diabetes. And more than 90% of people in the world who have diabetes have type 2 diabetes.
Wow.
And that is the type that is linked to obesity. Not
Okay,
type 1, which kind of develops earlier on, usually in childhood or adolescence.
great. Thank you for clarifying.
Yeah.
And the other thing I wanted to check as well is with the BMI, you had it in kilograms and meters. I'm guessing that for other parts of the world, like the US, where they tend to work in pounds and feet, they'd be able to do it that way. And I think as well, people can quite easily find BMI measurements online, can't they? So they can check their own BMI themselves as well.
Yeah, Emma, so there's a lot of like free, if you just Google BMI calculator and plug in weight and height, they'll do it for you. And BMI is interestingly one of those metrics that it has to be kilograms per meter square. So there isn't an equivalent calculation for other measurements, but you can definitely convert other measurements into weight in kilograms and height in meters, and then sort of calculate the BMI, if that makes sense.
Yes, thank you for that. I had no idea. I've always done mine in kilograms and meters. So yeah, that's
If it's weight in pounds, then you know the sort of the formula to convert pounds to kilograms, and then you can and then you're ready. So the thing with dyslipidemia, I mean, people with familial hypercholesterolaemia, they will recognize LDL. Low density lipoprotein cholesterol. So this is the lipoprotein, this is LDL, and we know it's atherogenic, it causes atherosclerosis, but there's also other types. And actually obesity and diabetes, they tend to increase this one, which is what we call the triglyceride-rich lipoproteins. Now, all of these are atherogenic because of this apolipoprotein B, which is like this purple circle. This purple protein circling the lipoprotein. And the reason it's atherogenic is that this apolipoprotein B, it has a receptor in the lining of the blood vessels. So basically, when it's circulating in the circulation, it will be taken up by, so these particles will be taken up by the blood vessels, and they will accumulate an atherosclerotic plaque in the vessel wall. This takes years to develop, and obviously depends on the levels of these lipoproteins, and the lower the lower you can keep them over an extended period of time, then the slower this process becomes. But with long-standing elevation of these atherogenic lipoproteins, you get this fat infiltration into the vessel wall, fibrous tissue accumulates, immune cells start accumulating. They engulf them, they form something called foam cells, and then with a bit of calcification, you've developed, your atherosclerotic plaque. Now you can see here that, you've got atherosclerosis, but you can still get some blood flow. So there's narrowing, but there isn't like total occlusion. And this goes on for a while. It can go on for years, especially since the plaque will develop a fibrous cap that will sort of hold it in place. But then in some people, this fibrous cap will rupture. And when this happens, the body sees this as a signal that, there's an injury here. We need to actually form a clot. So this is how thrombosis develops. So you get a thrombus that then blocks the blood vessel. If this is a blood vessel that's supplying the heart, the person will experience a heart attack, a myocardial infarction.
So am I right in thinking that although obviously it's causing the heart attack, the myocardial infarction, the body is actually thinking that it's got an injury and it's helping itself by creating this blockage because it thinks it's trying to heal itself, but it's not?
Yeah, it's one of these sort of mechanisms gone wrong. So it's basically if you are cutting up an apple and sort of you cut yourself, instantly your body. So what happens is that the blood vessel that gets cut, it recognizes, oh, there's a bit of a roughness there. We're used to everything being smooth. And instantly the platelets flowing in the blood vessel at the site of the injury, they will start accumulating and signaling to other platelets and to the fibrinogen to form a fibrin clot. And within a few minutes, your bleeding will stop. And that's the healthy sort of thrombus formation. What happens with atherosclerosis is that you get this roughness of the surface of the inner lining of the blood vessel that the body thinks is a signal as an injury, and that immediately sort of, it attracts, unfortunately, platelets and sort of the fibrinogen and forms a clot.
Okay. And
also,
go ahead, please go ahead.
Yeah, I know. I was just going to say that. So if this happens in the blood vessel of a heart, you get a heart attack. But if it's in the blood vessel supplying the brain, then the person experiences a stroke.
Right.
So the pathology is very similar.
Okay. And prior to this happening, would a person potentially have any symptoms with reference particularly to the heart attack? As in, in a months prior to that potentially happening.
So the event, we call it a cardiovascular event. So the thrombus event, there's nothing that tells you that this thrombus event is coming, that tells the patient. But what the patient could experience in the prior months is, if we go one step back, is during this narrowing phase, the person could be experiencing intermittent chest pain. Now, it's chest pain that will increase on exertion, because maybe this sort of narrow flow of blood is sufficient at rest, but when the heart starts to exert itself, if the person is climbing up the stairs or running, then the blood supply is not enough, and the person starts to experience chest pain. Now, typically, the patient will say that, oh, when I feel the chest pain, I rest for a few minutes and it goes away, or they will take a pill in the pocket medication, which will help dilate the blood vessel, and again, it will make the pain go away. What makes the myocardial infarction different is that the pain does not go away and is not necessarily linked to exertion.
Right. Thank you for clarifying that. Yeah, that was really helpful. Yeah,
brilliant. So, because this is FH Awareness Day, so where does FH come into all of this? Now, FH is basically, as people will know, it's a genetic condition where in most cases there's a genetic deficiency in the receptors that mediate the LDL uptake by the tissues. So the low density lipoprotein cholesterol accumulates in the blood, so people get hypercholesterolemia. Now, it is this type of particle that normally accumulates. So there is a dyslipidemia, but it's slightly different from the dyslipidemia caused by diabetes and atherosclerosis. And that doesn't mean that, obesity and diabetes do not increase LDL. They do increase LDL, but to a lesser extent. But with FH, you get massive elevations of LDL cholesterol. And as you see, this will trigger the exact same atherosclerotic process that is caused by obesity and diabetes.
Okay. Wow. So then, Amany, is there a direct link between FH and obesity and diabetes? For example, with somebody who has FH, are they more likely to have obesity and diabetes than, say, the general population?
Yeah, thanks, Emma. That's a good question. And it's, as you can see here, FH seems to be a sort of a standalone condition, independent of obesity and diabetes. And there's nothing to say that a person can't have both FH and obesity or FH and diabetes. But we wanted to ask that question a bit more clearly and say that, how prevalent is obesity in patients with FH? Now, you may have heard of the FHSC registry, which is the Familial Hypercholesterolemia Studies Collaboration Registry. It's a global registry spanning more than 70 countries. And to date, in the registry, we've got data from more than 70,000 patients, and that is from all 6 continents. So it's a very rich resource for investigating the risk factors for disease in this patient population. We ran an investigation using data from this registry. We had approximately half of the patients in the registry had data on their BMI, and this enabled us to ask the question is, how common is obesity and in patients with FH? And we use just exactly as you would in the general population, we use the cutoffs that you would normally use for normal weight, overweight, and obese. Yeah. And for children, because weight is kind of age and sex specific, we used World Health Organization Z-score cutoffs to define normal weight, overweight, and obesity.
May I just ask, I really don't know this, what's a Z-score cutoff?
So it's basically, it's a stat approach where for every child, for their age and sex, you ask yourself, you don't ask yourself what their exact weight is, but you ask yourself, where are they compared to the average child of the same age and sex? And then you start this, where are they? We measure it in standard deviations. And then you get cutoffs based on how many standard deviations are they away from the average, if that makes sense.
That makes perfect sense. And I'm just wondering, is it a little bit like the, certainly, here in the UK, we have the percentile for particularly for newborns when they're coming up through sort of, 6 months and things, and they're in this percentile for body weight, etc. Is it similar to that?
Exactly. It's exactly similar to that. Yes.
Okay, good. That's very helpful. Thank you.
Yeah, thanks, Emma. So we sort of categorized our children and adults, and these are children and adults with heterozygous FH. And basically, this is what we found. So if you look at the percent of patients who are overweight or obese, so basically an unhealthy weight, we found that approximately half of our FH population are overweight or obese, and approximately half of a quarter of the children are already overweight or obese. Now, you may ask the question of, how does this compare to people without FH?
Exactly what I was going to ask, yeah.
And let me tell you that it's very similar to what you would get in people without FH. So these are stats from the World Health Organization from 2020 for adults in the general population. And you can see here that for most of the world, you've got at least 50% are overweight or obese. So very similar, and nothing to say that people with FH are protected from overweight or obesity, or vice versa. It seems to be a similar prevalence to the general population. And what we also found was quite similar to the general population is the association between this overweight and obesity and disease. So this is just a cross-sectional snapshot. So we didn't follow up our patients to see if they develop diabetes or cardiovascular disease. We were just looking at them at one time point. But what we saw in this one time point is that patients with obesity were more than 4 times as likely to have diabetes than patients without obesity. And they were twice as likely to have coronary artery disease, and about 1.5 times as likely to have stroke. So again, the patients appeared equally susceptible to the detrimental effects of obesity as the general population.
Okay, so what you're saying is there isn't any correlation between having FH and being obese. It is just the same as it is for the general population. But I guess if you have FH, then maybe you may need to pay more attention to lifestyle factors. Yeah,
exactly. So they are just coexisting conditions. None of them leads to the other, but the thinking is that if a patient with FH is already at increased risk of cardiovascular disease from their genetically high LDL cholesterol, then it would be very helpful if that patient also managed sort of body weight and exercise to decrease the risk of developing diabetes and coronary artery disease. And the good news is, at least from the general population perspective, now we don't have these data in FH, but hopefully soon. But from a general population perspective, it is very well known that weight loss will reverse a lot of the abnormalities that I explained earlier. So weight loss will bring back the insulin sensitivity. It will again make the tissues more sensitive to insulin. In some patients with diabetes, in a good chunk of patients with diabetes, shortly after diagnosis, if they lose weight, they can get in remission. So they will not need glucose-lowering drugs. It reverses a lot of the toxic effects on the cardiovascular system, kidney function, and primarily it improves the dyslipidemia because it decreases the atherogenic triglyceride-rich lipoproteins. So weight loss. So even if a person is obese, weight loss will reverse a lot of the abnormalities that ultimately result in atherosclerosis.
Wow, that's phenomenal. Weight loss incredibly hard, but the benefits that come with it from a cardiovascular perspective and also diabetes perspective are huge. You can live by living a much more healthy life, you can actually be less prone to cardiovascular disease as well, and reverse any type 2 diabetes potentially.
Yeah, exactly. It is phenomenal, and it's very interesting that the person doesn't even have to go back to their normal weight. So if a person loses as little as 5%, but ideally 10% of their body weight, they will start to see measurable improvements in these organ functions, even if they have not gone back to a completely normal body mass index. So any weight loss helps is probably the message.
But yeah, something is better than nothing.
And something is better than nothing, exactly. Yeah. Okay, so I'll just wrap up. I think we have a simple take-home message from our work, is that individuals with FH are as susceptible to obesity and diabetes as the general population. And probably, although we haven't shown this in FH, but probably they will stand to equally benefit from the weight loss as is seen in the general population and is quite well evidenced. And so, as you said earlier, Emma, given their already high risk of CVD, management of weight and lifestyle should be a priority in patients with FH. Thank you very much.
Thank you, Amany. I just have a couple of more questions for you, if that's okay. So for somebody that's got FH and they are taking statins, from your previous slides and what we've already discussed, I assume that they would also need to exercise and eat healthily as well. So statin is incredibly important, but you can't rely on it completely. You need to exercise and eat well too.
Yeah, that's absolutely right, because they kind of target different things. So statins are targeting the low-density lipoprotein particle, and it will bring it down. And in that way, you have controlled the risk associated with FH. But the atherogenic triglyceride-rich lipoproteins will continue to increase and cause atherogenesis if there's obesity. So they tackle different things. And yes, to decrease the risk of CVD, you want to come at it from both angles. So both the statins and the weight management.
Okay. And if you're diagnosed with FH during childhood, do children need to watch their weight as well then? Because going back to one of your previous slides with the general population, it was quite clear that obesity in childhood is also quite prevalent. So I'm wondering if that's also important then too, if you have FH in childhood.
Yeah, so that's correct. I mean, we think that a person diagnosed with FH in childhood is lucky to have been diagnosed in childhood. I mean, it just allows much earlier control of the risk factors for CVD and decreases the cumulative exposure to the atherogenic lipids over the years, which ultimately results in atherosclerosis. So yes, definitely, that is an amazing window of opportunity to start leading a healthy lifestyle, prevent weight gain, unhealthy weight gain, as well as control the LDL using medication. Yeah.
Great. Thank you. Thank you for answering those questions. And thank you for such an informative presentation, Amany. It was very, very helpful. And I'm sure our viewers on our YouTube channel will really appreciate what you've put together here. And as I said, very informative. Thank you very much.
Very much, Emma. Thank you for having me.
Thank you.